today's meeting. As we all know, POCUS, point of care ultrasound, has now been increasingly accepted as by the healthcare professionals across medical specialties, and POCUS is now been referred as the fifth pillar of bedside clinical examinations, in addition to the traditional ones of inspection, palpation, auscultation, percussion and auscultation. It's our pleasure to have Dr. Abhilash Koratala from Medical College of Wisconsin with us to enlighten us on the use of POCUS in nephrology practice. Here at our place in Vidarbha, as far as the practice of nephrology is there, we have a very limited use of POCUS. And few of our nephrology colleagues, they are using it in an ICU setting, not as a standard of care, but in tricky situations for assessing the volume by looking at IVC diameter and the respiratory variations, in the setting of insertion of a hemodialysis catheter in difficult settings only, and few of us are using it for native kidney biopsies. And we have not been trained dedicatedly, we have not been trained with hands-on training for this, and whatever little practice of POCUS which we do in our day-to-day clinical practice is what we have learned from our fellow colleagues. So most of us would agree that the POCUS is of benefit in our day-to-day nephrology practice. And for today's talk on the chair, we have Dr. Nishant Deshpande and Dr. Amit Pasari, two prominent nephrologists from Nagpur. I once again welcome you all for today's meeting, and I hand over to the chair for further proceedings.
Thank you, ma'am. Good evening, everybody. I am Dr. Amit Pasari. Today, as Madam pointed out, we would be discussing about point of care ultrasound in nephrology. As we know, ultrasound can be used for delineating the kidney anatomy in our patients. Apart from that, it can also be used for various interventions like USG guided sonography, USG guided catheter insertion, USG guided catheter insertion. And apart from that, it can very well be used for knowing the fluid status of the patient, the most vital parameter that we are many a times are supposed to monitor for our patients. So to guide us about the use of ultrasound in nephrology practice, we have Dr. Abhilash with us. Dr. Abhilash is Director of Clinical Imaging for Nephrology at Medical College of Wisconsin. He runs a POCUS video curriculum for nephrology fellows. He is Associate Editor of POCUN for Renal Fellow Network. His website, nephropocus.com, has been awarded with ASN Innovation in Kidney Education. It has also been awarded with as a social media project by NephJC. So we welcome Dr. Abhilash, and over to you, Dr. Abhilash.
Let me share my. Is my screen visible or?
Yeah, it's visible.
Is it good now?
Yeah, it is good.
Okay, very good. So thank you so much for having me there and for the kind introduction. So yeah, the focus of today's talk is POCUS. We'll talk about basically physical examination, the era of sonoscope is ultrasound, essentially like stethoscope. As you rightly pointed out, point of care ultrasonography is essentially a component of physical examination. And I do not have any disclosures. So the way this presentation goes is, first briefly I'll introduce you to POCUS. concept. And then we'll see what are its applications, like how we can incorporate POCUS in day-to-day nephrology. So the first, what is POCUS? POCUS is a focused point of care ultrasonography exam or a limited ultrasound exam that a clinician performs at the bedside. Not the radiologist, but the clinician who treats the patient performs at the bedside to answer focused questions. And what are these focused questions? In general, after you take patient's history and perform conventional physical examination, you still have some questions in mind, answering which will either narrow your differential diagnosis or provide the final diagnosis. And you can also use point of care ultrasonography to guide a bedside procedure, like a dialysis catheter placement or native or transplant. And some examples of focused questions are, say you're seeing a patient with acute injury and you need to rule out all the different causes. The easiest thing to rule out, and that can be easily addressed, is obstructive. You want to know if the patient has hydronephrosis or not. That's one common focused question. Or does your patient with abdominal pain have gallstones, and that's causing the pain and not renal colic? So that could be one. Or does your dialysis patient with hypotension have pericardial effect? Or is the left ventricular systolic function looking okay? These are some common focused questions you would want from cardiac ultrasound. Or is your patient who is having shortness of breath, is it because of pulmonary edema, or is it because of pleural effusion? Or is it pneumonia or something else? Maybe it's something unrelated to lungs. That way, you get your answers right away without wasting time. You don't need to wait for radiology to perform some kind of imaging test. So, yeah, like Dr. Shri said, it's POCUS is a component of physical examination in addition to inspection, palpation, percussion, and auscultation. And we call it insonation. And till not too long ago, POCUS in nephrology was confined to just bedside dialysis catheter placement. I mean, you use point of care ultrasound to perform kidney biopsy to guide needle entry, but usually at most places, at least in US, done by the radiology department. Ultrasound technologist will hold the probe for you and you put the needle. So it's not really a point of care exam. That is it was primarily confined to dialysis catheter. But in the recent past, we've been using it for several purposes, and we are using it as a component of. You can use it in evaluating hyponatremia when there is difficulty in evaluating the volume status, or in patients with cirrhosis and presumed hepatorenal syndrome, where you would give patients a lot of albumin without really checking the volume status. So by the time you see a patient with presumed hepatorenal syndrome, maybe the patient already is hypervolemic and you do not need to give, or the patient has a lot of significant cardiac output because of high output cardiac failure in cirrhosis. And maybe, if the patient has like 8 liters of cardiac output, what point of giving albumin? What are you trying to do by putting more albumin in the system? The cardiac output is already high. So these kind of common questions POCUS will help us answer. Another practical example, you are rounding in outpatient dialysis. A patient has hypotension and you are thinking in lines of maybe this patient has pericardial effusion, or maybe there is significant aortic stenosis. The dialysis patients have accelerated valvular calcification, and you can have calcific aortic stenosis. Anything like that. So you have some focus in mind. Normally, what you would do is you call and make an appointment, and the patient goes to some outpatient scanning center. The technician performs a scan, and then the cardiologist reports the echocardiogram. So it's a process of few days, because dialysis takes place 3 times a week, and the patient can only go to these places on off days. It takes time, maybe at least few days. And on the other hand, if you are able to perform point of care ultrasonography yourself, these days we have pocket devices and all these things. you get the answer right away in just few minutes. You know if the patient has pericardial effusion or not. If there is pericardial effusion, is it significant amount or not? Do I need to do anything at this time? Or could it be contributing to patient's hypotension or not? So yeah, that's one practical. And yeah, other thing is that we tend to overestimate our physical examination skill. I mean, it depends. It might vary from country to country depending on our practice setting. But in general, the sensitivity of conventional physical examination is low. For example, this was published in 1989, and they looked at 50 patients with chronic heart failure with mean ejection fraction 18%, and who had elevated pulmonary capillary pressure. In these patients with, fairly advanced heart failure, the combined sensitivity of rails, pedal edema, and elevated JVP was only 58%. Specificity was fine. It's just that all these classic signs and symptoms of most diseases, they are described patients with advanced presentation, when the patients were presenting late. But now we have the opportunity to detect abnormalities earlier so that we can provide appropriate management. And similarly, using point-of-care ultrasonography increased the sensitivity of. So, for example, there was a study in dialysis patients where they looked what is the sensitivity of lung crackles and peripheral edema, detecting significant congestion, significant pulmonary congestion. And what do you mean by significant pulmonary congestion? So normally when you ultrasound the lung, you cannot really see the lung tissue itself because lung is filled with air and air is reflective to ultrasound. So what you would see is artifacts. So this is normal lung on the left-hand side, and this is the pleural line on the top. And if the lung is filled with air, you see these horizontal reverberation artifacts, or you can say horizontal reflections of the pleural line. Those are called A lines. That's normal lung, how it appears. And when you start to see these vertical lines, those vertical lines indicate fluid in the lung. They are called B lines. And these are analogous to Kerley-B lines in chest X-ray. So the point is that in that study, they were looking at B lines as a standard for pulmonary congestion, and more than 30 B lines in the 28 zones that they auscultated. So when you more than 30 B lines is fairly significant amount of B lines indicating significant pulmonary congestion. So to detect that amount of pulmonary congestion, the sensitivity of crackles and peripheral edema was only 9% and 3% respectively. Though the specificity was high for the same reason mentioned before. And so that way, POCUS helps you to identify asymptomatic lung congestion, and you can adjust dry weight better in this dialysis. And similarly, focused cardiac ultrasound or focused echocardiogram has much better sensitivity to detect either LV dysfunction or valvular heart disease when you compare to auscultation. Okay, and it's not just comparison with traditional auscultation. You can also compare lung ultrasound with chest X-ray, and it is more sensitive. So, for example, this was one of the relatively older studies, but this is a study you can say that that made everybody interested in lung ultrasound, and ICU people started to incorporate more and more of ultrasound. They looked at 32 patients with acute respiratory distress syndrome, and also they had 10 healthy controls. So the sensitivity of lung ultrasound was way superior, even when you compare to auscultation, chest X-ray for the detection of pleural effusion, alveolar consolidation, and alveolar interstitial syndrome, that is pulmonary congestion, pulmonary edema. So the sensitivity of ultrasound was always more than 90%, even beating chest. And there are other studies, ICU setting, which showed lung ultrasound was much sensitive. So a fun fact is that your stethoscope is not really a scope, because scope means to see or to view, and stethoscope should be ideally called a stetophone. What is the real scope? It's sonos or ultrasound. So people who advocate for using point of care ultrasound, you can say they are ultrasound extremists. They say that these are the uses of stetophone these days. Stetophone is used to detect wheeze or rub or when you don't have a reflex hammer or knee hammer, you use your stethoscope to elicit the knee jerk. Or I would say stethoscope is mostly a placebo tool. So you wear a stethoscope, you listen to patients' lungs, they feel better that the doctor is doing something. So it's pretty much that in most circumstances. So it's a kind of exact. Anyway, so one of the reasons that really facilitated proliferation of point-of-care ultrasonography is the availability of newer tools and relatively less expensive tools and miniaturized tools that they fit in your pocket. So on the left-hand side, you have the traditional machine. Of course, I mean, you need these kind of bigger machines to perform advanced applications. You want to perform a perfect Doppler echocardiography to look at valvular gradient. You still might need this, or you want to perform some elastography, you still need. But for most purposes, the way you are using point-of-care ultrasonography as physical examination, the smaller machines are good. In the middle is the laptop-based that's commonly used in our hospitals. And on the right-hand side, you have even what we call the handheld ultrasound devices or the pocket devices, which really fit in your whiteboard. So the top one is Lumify. You can just connect it to a tablet or your smartphone and do the ultrasound. Or the bottom one is V-scan. It comes with its own display device. It's like old Samsung flip phone, right? If you're old enough, you recognize those Samsung flip phones. So yeah, it's as small as those things. So this is me. This thing is our big machine. We need bigger machine for certain purposes, like I said. But also in my hand, you can see a small point-of-care device, the wireless device that you can connect to your smartphone. So if your purpose is just to look at lung B lines or A lines, a very quick look at the heart, these devices are adequate. But if you want to do a little more advanced stuff, so you're talking about what's the scope of POCUS in nephrology, right? It's very wide, and there are so many applications you can do with point-of-care ultrasonography. It's not just restricted to procedural guidance. And for that matter, I mean, at least from my standpoint, we rarely do any. I don't put any dialysis catheters. I put that in residency. After that, I never really put in our academic hospital, even in private practice. I hear that people. It's those temporary lines are usually placed by interventional radiologist or ICU physician. But regardless, so yeah, you can use POCUS in several ways. So for example, you can use it to guide catheter placement, or you have a patient with hypertensive urgency and you don't have your ophthalmoscope. You can look at papillary edema using ultrasound, or your patient with shortness of breath can right away evaluate for pulmonary edema, pleural effusion. This is COVID pandemic time, so lung ultrasound is immensely helpful in patients with possible COVID infection in the lung. And the heart ultrasound you can do to if there is any cause for hypotension that can be explained by pump function or pericardial effusion, or is there any gross chamber enlargement in a patient with pulmonary embolism or elevated left filling pressures. So you can answer several questions like that, and you can scan arteriovenous axis and look if there is any thrombus or any pseudoaneurysm, or if there is any stenosis of the axis, or your CKD stage 5 patient coming to your clinic, you can assess the maturation of fistula yourself, and you can go scan the liver area, so you get to inferior vena cava, estimate right atrial pressure, and you don't stop at inferior vena cava, then you go downstream and see if the organs are feeling congestion, how the blood flow is in the portal vein or hepatic vein. Those things you can assess. And obviously in the kidney, you rule out hydronephrosis for renal parenchymal characteristics, guide renal biopsy. Similarly, in allograft ultrasound, you guide biopsy, you look for any perinephric collection, post biopsy, AVFs, and all those things. And the bladder, it's a very common scenario that patient has Foley catheter but still obstructed because the Foley catheter is blocked. Those kind of things you can very easily look using point of ultrasound. The patient has peritoneal dialysis catheter, comes with abdominal pain, in addition to treating peritonitis, you can easily rule out if there is any abscess or any tunnel infection. That way, you get off that catheter right away instead of waiting for the cell count to come down. Or you can also scan for deep vein thrombosis in your patients with nephrotic syndrome or patients with high likelihood of forming clots. Yeah. You can rule out deep. So with that understanding, with that background of POCUS, we'll go see some real life cases in various clinical settings. Yeah, and I want to make sure that you realize POCUS is not limited to ICU and regular ward patients or benefit from POCUS as much as ICU patients do. That's why I made the talk into different practice settings, and we'll see something. So in 3 slides, I put together the basic things that you need to understand to interpret the ultrasound images better. So there are 3 common types of probes or transducers we use. There are small handheld devices that come all in one probe, but for all practical purposes, we need to know these 3 types. The first thing is called the curvilinear probe. It has a curved footprint. Footprint is nothing but it's just the mouth of the probe, the place where your ultrasound beam is coming. So curvilinear probe, and it gives a wide image, and it has a lower. So low frequency probes are used to image deeper structure because the ultrasound waves penetrate deeper, have low frequency. So this is the abdominal probe. This is the probe you use to perform a kidney or any abdominal ultrasound in general. And the middle one is the phased array probe. It's also called the cardiac. It's also a low frequency probe because you're looking at the heart. It's a deeper structure, but it helps to image the moving structures better, and it gives a better definition when there is blood flow. And the last one is the linear probe, or you can also call it the vascular, and it's used to image superficial structures. And it's a high frequency. That means it offers high resolution, but it cannot penetrate deep. So those are the 3 common transducers. And when it comes to image orientation, you see some kind of a dot or a letter corresponding to the ultrasound manufacturer on the screen. That's the orientation marker. So that corresponds to the orientation marker on the ultrasound probe. So it depends on which direction you are holding the probe. If you are holding the probe with the orientation marker on the probe towards your head, which is what we do in general abdominal scanning, this part of the image becomes towards head, and the opposite side of the image becomes towards feet. And also the structures that are closer to the probe are displayed on the top of the image, and structures away from the probe are displayed at the bottom. And the same rule applies to structure to your image. And the appearance of various structures on ultrasound, in general, stones, bones, fibrous structures such as diaphragm, they appear white on ultrasound, or they appear bright on ultrasound because they reflect most of the ultrasound waves you are hitting. And air also is bright. I highlighted that because it's very important to realize air is bright or white on ultrasound because we are so much used to seeing it as a black structure. And black structure on chest X-ray or CT scan. And clear fluids such as blood, urine, fluid in a simple cyst, they appear black on ultrasound. They appear black on ultrasound because they allow excellent transmission of ultrasound waves. So reflect more, you are more bright. You reflect less and transmit more, you're more blackish or anechoic. And most of the soft tissues appear in different shades of gray, such as kidney or liver, all these things different shades of gray. And okay, so the first setting is the intensive care. So let's see a case. We have a 57-year-old lady who presented with fever, abdominal pain, and nausea. And she was also found to have hypotension and leukocytosis. So the emergency medicine physician has obtained a CT scan, and a CT scan without contrast because there was some acute kidney injury. It only showed mild hydronephrosis. Apart from that, there was no obvious source of sepsis. So what they did was the surgeon came, the patient had abdominal pain, obviously, so they suspected some intraperitoneal cause. They did exploratory laparotomy, but there was no obvious source. And finally, nephrology was consulted to initiate continuous renal replacement therapy for acute injury. But before putting somebody on CRRT, you want to do examination, right? So, and POCUS is a component of the examination. So you do the basic kidney ultrasound. And how does kidney appear on ultrasound? So on the left-hand side, you see a normal image of, so on the top of the image, because you're imaging kidney to the liver from the flank. So structures close to the probe are on top of the image, right? So liver is on top of the image when you're imaging the right kidney, and spleen is on the top when you're imaging the left. And here is the kidney. You have parenchyma outside, and the echogenic structure or the bright structure in the middle is the sinus fat that encases the collecting system. In parenchyma, you can have cortex and darker medullary. Whether you see them well or not, it depends what probe you're using, what you're using. But in general, it has parenchyma and fat. But when you have hydronephrosis, which is the right-sided image, hydronephrosis is fluid. So clear fluid is black on ultrasound, or anechoic, because it's not making any echo. So you see a dilated collecting system here, and the sinus fat is all dispersed out. So you don't see a bright structure in the middle anymore, but you see a anechoic branching structure. That's how hydronephrosis appears. So with that understanding, we'll see what happened to this patient who presented with fever and mucositis. So this is the ultrasound image we got from this patient. So it appears that there is some hydroureter, there is some clear fluid here in the urine. And here, there is some ugly looking echogenic structure. And this is not tank hydronephrosis, clear hydronephrosis. And here also you can see that the collecting system seems to be distended. Ureter, hydroureter, the collecting system with anechoic urine. But in the middle, there is some ugly looking echogenic structure that is pus in the collecting system, or pyonephrosis. So that was the source of sepsis. So what happened with the initial CT scan? CT scan is not foolproof, right? If you don't give contrast, you will not see pyonephrosis. When you give contrast, you see pyonephrosis as a layering debris. So that's what happened with this patient, and unnecessarily she underwent exploratory laparotomy. So we call urology, they put nephrostomy tubes, and the patient went home without any CRRT. She required CRRT initially. After that, the renal function recovered fine, and she went home happily. So simple point of ultrasound examination can identify important causes. And pyonephrosis, another example. This was another patient in the ICU setting. Obviously in this patient, you can see this urine looks very ugly here. And when you look at the kidney ultrasound in the middle, is dilated collecting system, and it's not black, but there is some echogenic debris in the collecting system that must be with this urine. This patient has urine, so it's relatively easy to identify something is wrong. But the previous patient was completely anuric. That makes it a little tricky. And this thing here, don't bother about it. That's just a another patient in ICU. So this patient was already on continuous veno-venous hemofiltration. We were following the volume status. So we were looking at inferior vena cava and portal vein and all those things. But and assessment of volume status is never complete without the heart. So we look at the heart and to look at the pump function and stuff. And we find something odd here, like close to the liver, right? So let's see, let's orient ourselves to the image. So this is a subxiphoid or subcostal heart. That means our probe location is in the subxiphoid area, and we are looking at the heart through the liver. That means liver is on top of the image and followed by the heart. So the chambers that are closer to the liver must be right side. So this is RV, RA, LA, and L. Now you go back to the image. Okay, so in this image, on the top is the liver, and this is the RV, RA, LV, LA. So you see this echogenic structure and that must be some kind of clot. I mean, you can also assume it's vegetation, but the patient history doesn't fit. Generally, vegetations you expect in some IV drug abuse or ESRD patient with catheters or something, and patient has fever or embolic. But this patient did not have any of those, and it was assumed to be a clot, and she was given IV heparin, and in a few days that thing disappeared. So just changed management. And people argue that if a patient has a formal cardiology performed echocardiogram available in past few days or even the last month, like why would you do or why would you image the heart? We image the heart because you might find something. And it's like Oscar patient, right? Nobody argues. The patient has echocardiogram. Why should I Oscar treatment? So similarly, you would insunate the patient also. Okay. So another ICU patient we have here who had AKI and not making urine and has a Foley catheter. So people assume that there is no upstream, right? And ICU resident calls you saying, hey, we need nephrology consult because we have this patient who is anuric. He has Foley, we ruled out obstruction, we need CRRT. Okay, so, and obviously we need to examine this patient using POCUS. So how does a normal urinary bladder look like on ultrasound? It's pretty straightforward because it's black or anechoic because it's filled with urine, which is a clear fluid for ultrasound. So when the bladder is full, in the transverse plane, it appears more or less rectangular. In the longitudinal plane, it appears more or less oval. But whatever that is, it's more anechoic extended structure. And when you put a Foley catheter and inflate the balloon, so you basically decompress the bladder. So there shouldn't be any urine in the bladder. You have a Foley catheter balloon inside the bladder. So Foley catheter balloon you fill with fluid, right? So that fluid is again black or anechoic on ultrasound. It appears like a nice cystic structure. So a decompressed bladder should be like this. So you should have a Foley balloon within the bladder, and the bladder is pretty decompressed. You don't see that urine bladder any longer. You might see a little bit anechoic streaks here that just remnant urine that's completely normal. So now let's go back to our patient. So this is what ultrasound from our patients, that ICU patient with anuria. Here you do have this Foley catheter, nice, the Foley catheter balloon, a nice cystic structure. But also the bladder is distended, which you normally shouldn't have this distension. Right? If you have a Foley catheter, that means the Foley catheter was blocked. So simple solution is not doing dialysis, just flush the Foley catheter and see if the patient starts to make urine. So that's one simple. So here another patient. This patient had cirrhosis, and same like the previous patient, he was not making any urine. Has Foley catheter, and they did a bedside bladder scanning examination. So in most of our wards, there are these blind bladder scanners. These are automated bladder scanners. You just put them on the bladder and they give you reading approximately how much urine a patient has. And nurses use it very commonly, especially the ICU. So that bladder scanner has read there is 450 cc urine. So the nurse has flushed the Foley catheter, assuming there is some Foley obstruction like the previous case, but there was still no response. In the meanwhile, nephrology was seeing the patient and we performed the examination. And here you can see this bladder-like structure looks anechoic, and yeah, indeed, there is some distension here, but I don't see any Foley catheter balloon. So now you move the probe or fan the probe up and down, and now you see something here. This thing here. Closely see, this is the Foley balloon, right? So the Foley balloon is not that anechoic structure. Also, you know that this is not really a well-defined bladder, fairly irregular structure. So what's the real deal? That's the pelvic ascites we are looking at. Remember, we said the patient has cirrhosis. Right? So that was really the pelvic ascites, because the ascites is also a clear ultrasound purpose, and that appears black. And the identification is you go a little upwards, you see that with in continuity with the rest of the. And this thing here is the Foley balloon, and the bladder is appropriately deep. So this patient really needs some kind of dialysis. This, urology is not going to do it. So similarly, like this image was obtained from another patient with pelvic ascites. So So what does it appear like? It appears like a TIE fighter, right? This is called the TIE fighter sign. The TIE fighter is some jet from Star Wars. Here in the middle, what you see is the uterus transverse section with the ligament. And above and below, you have this pelvic ascent. This is also a common site, the ICU setting. And the same patient, when you rotate the probe in the longitudinal section, you can see that the above and below continue to be. This is all pelvic site is surrounding the uterus. We should not be. And these automated blind bladder scanners will confuse this with you can also have this kind of scenarios. You can place a Foley and what's happening here? So there is bladder here. It appears nice and distended. There is no Foley catheter balloon, but the Foley catheter balloon is here and surrounded by some tissue. And what is that tissue? That's prostate. So you can prematurely inflate a Foley balloon in prostatic urethra and cause iatrogenic obstruction. And you can detect these things very quickly. And in female patients, you can inflate Foley catheter balloon in vaginal, right? And if it's an ICU patient, critically ill patient, they will not complain of pain. So that can happen too. And you can see this vaginal canal is just posterior to the urethra, so it's not at all uncommon. And okay, that's about ICU. So now let's go to some cases that we see on the regular medicine ward. We have this middle-aged patient with known low ejection fraction of 20% who was admitted for non-healing some leg ulcer, diabetes related, possibly requiring amputation. And the baseline serum creatinine was 1.72 milligram per deciliter. And at presentation, it was 2.4, slightly elevated compared to baseline. And the admitting team has resumed the home dose of Bumix. Obviously, I mean, he's on maintenance diuretics, he has heart failure, so you need to resume the home dose of diuretics. And 2 days later, the creatinine was continuously going up. It was going to 2.6, then 3.1, and then 3.3. And the team has obtained FE urea, and it was 18%. So that means it was less than 35%. You're assuming some pre-renal cause. And this was the physical examination documented by the primary team or medicine team. And they were writing, I mean, there was no mention about JVD, and they say chest is clear to auscultation bilaterally. So they did not hear anything. And so taking this data into consideration, they were thinking more in lines of maybe it's more volume depletion that's causing this AKI. And to add to that, the documented fluid balance was minus 860. This is the net fluid balance that was documented in the chart as minus 860. And strangely, even the weight, they documented it to be 8 kg less than that of admission. So everything points in terms of volume depletion. So in regular scenario where doctors do not perform focused enhanced physical examination, with this data, anybody would assume this is pre-renal, meaning volume depletion related AKI and whole Bumix, right? But we did perform. So just looking at the heart, nothing really unexpected here. This is the apical 4-chamber view. Here, these are the left-sided chambers and right-sided chambers. And this is the tricuspid wall. There is a little bit of tricuspid regurgitation expected in anybody with enlarged chambers, right? And you can see that the LV is not contracting as much. But nothing that we don't know of. He has EF of 20%, so that's not bad. But looking at the IVC here, so IVC seems to be big. Note the scale on the right-hand side, right? So it's at least 2.1, 2.2 centimeters. And it's not really collapsing with inspiration or deep breath. Here, part appears to be collapsing a little bit, but that's not real collapse. That's just diaphragmatic pull. So here you have the right atrium, you have the inferior vena cava. So in the middle, you should have the diaphragm, right? So that the diaphragm has some pull effect. So that's why you do not measure IVC diameter at the IVC dilated junction, or you don't even measure exactly at the hepatic vein IVC confluence. But you go slightly inferior to hepatic vein IVC junction, and that's where you measure the diameter. That's where you get the most accurate diameter. So it's pretty plethoric, not collapsing with inspiration. Why would a volume-depleted patient have plethoric IVC? And next step is to, unless they have significant chronic pulmonary hypertension, right? But that degree of tricuspid regurgitation we saw, a little bit of regurgitation, it's very less likely that the patient has so much tricuspid injury, a lot of pulmonary hypertension going on. So next step, what we should do is we should perform a venous Doppler ultrasound. So look at hepatic vein Doppler, portal vein Doppler, and the renal parenchymal vein Doppler. So what it is, it gives adjunct information about this IVC ultrasound. It will tell you how the organs are feeling the congestion. The initial reaction of IVC is to distend, right? When the RAP or the right atrial pressure is high, the inferior vena cava is distended. After that, the organs start to feel the effect. So you see alterations in the blood flow. So my purpose of this talk is not to discuss all these things. Just to simplify, I will just discuss the portal vein Doppler because it's very simple. And there was this recent study where they looked at just high level of CVP of more than 12 millimeters mercury versus adding all these venous congestion parameters to look for the probability of AKI. So that's called VEXUS study or venous excess ultrasound study. So the probability of having AKI or organ injury, the event of a positive test, was much higher when you use the whole VEXUS rating as opposed to using CVP. CVP is essentially IVC, right? So that tells you that you need to add more things to be able to precisely assess organ injury. So this is how the portal vein Doppler of that patient looked like. So it's very pulsatile with some below the baseline flow. So how is normal portal vein supposed to? So normally, portal vein is supposed to look like this. All the waveform is above the baseline, and it's more or less continuous with minor fluctuation or minor pulsatility. And as the right atrial pressure increases, the pressure is transmitted back to the portal vein, and the portal vein becomes more and more pulsatility. Here you can see little more increased pulsatility. Here the pulsatility is almost 80%. Here there is 100% pulsatility with some flow reversal. Now you go back and see your patient's portal vein. So it's 100% pulsatile pretty much with some flow reversal. So that's severe congestion. That means organs are feeling the congestion, and his AKI is most likely related to fluid overload rather than a volume depletion, as suggested by conventional parameters. So I want to remind you that these conventional parameters are not really accurate, neither physical examination parameters nor documentation that's available in the chart. You can always move the patient from ward to ward, observation unit to the medical floor. Your weighing scale can be different, and there are a lot of variables. So you need to examine the patient and see what needs to be done. So we initiated diuretic therapy and see how the portal vein has improved. So this was the initial portal vein on the left-hand corner. And here on the right-hand side, the top image shows mild improvement, though it is still pulsatile. Follow-up 1. And second follow-up, you can see the pulsatility has significantly, and on follow-up 3, the pulsatility has almost disappeared and the portal vein has become normalized. So these waveforms not only help you to diagnose congestion, but also help you to monitor the efficacy of decongestion. You can give diuretics, dialyze, and see how these waveforms are changing with therapy. And here is the patient's IVC. So it became just like, this is the initial IVC on the right-hand side. Well, IVC is normally supposed to be a little elliptical, right? Elliptical and smaller than the aorta. Here, this one is much bigger and more roundish. That tells you that IVC is distended. And here, at the time of discharge, IVC became a split. And here is the aorta here. And it's much smaller compared to aorta. While in this image, that IVC is much bigger than that of aorta. So essentially, you can say, why can't I just use IVC, right? In this patient, you are just lucky that the patient doesn't have chronic pulmonary hypertension, but in some patients, IVC won't get better. So, for example, here is another patient with heart failure exacerbation. So this is the IVC on day 1. It was big and round. This is IVC on day 6, still big, more than 2.1 with minimal collapsibility. Portal vein changes nicely in the patient. As you can see, initially it was discontinuous, very pulsatile with some below the baseline flow reversal. On day 4 with diuretic therapy, it is pulsatile, but much better than day 1. And on day 6, it's almost continuous, while the IVC is still big. So that's the advantage of adding these waveforms to your examination. And here is your another patient, a heart failure patient on the medical ward. So this patient has undergone some kind of cardiac surgery. The patient was feeling better, and the documented fluid balance was net negative 7.5 liters. And everybody was fine. And okay, but the physical examination of the nephrology team has showed this. So in the lung ultrasound on the left-hand side, here's the pleural line. You see these vertical artifacts suggestive of B lines or fluid in the lung. And here is the portal vein from the patient. It's very similar to the previous patient that I have showed. So it's very pulsatile, 100% pulsatile with some flow reversal. And IVC was more than 2.3 centimeters, more than 2 centimeters. So this patient is very likely to be congested. But what does physical examination say? There were 2 subspecialty notes from the same day, and both of them documented the lungs were clear to auscultation and bilateral air entry, and nothing about jugular venous distension. So they were eager to discharge the patient. But and actually the patient went home and came back to the hospital in just 3 days with volume overload and admitted to cardiac ICU and had a prolonged admission. And this time, the patient was decongested well, and at the time of discharge, we made sure that the portal vein has become more or less continuous at the time of discharge, so that you know that it is safe to discharge. And here is the IVC. It was still big at the time of discharge. It was still 2.1 centimeters, even during second admission. And let's see a scenario in the emergency department. We have this ESRD patient who presented with shortness of breath, and the patient missed two dialysis sessions, and dialysis was initiated in the ER. When the chest X-ray was pending, the patient became hypotensive during dialysis, and the nurse called the resident, and the resident says, okay, the blood pressure is low, so stop ultrafiltration. It's a simple thing, right? But you need to think why a patient who missed 2 hemodialysis sessions has low blood pressure during dialysis. Why would the patient become hypotensive when you're removing excess fluid? So you perform a physical examination. So you look at the inferior vena cava. This is relatively big and not at all collapsing. Even this hepatic vein seems to be distended. So that means the tank is full. So there seems to be a lot of fluid, or at least pressure in the heart for whatever reason. Then you look at the heart, the same subcostal or subxiphoid 4-chamber view, and there is heart, there is liver, but you see this black thing surrounding the heart, and on ultrasound, the black thing is pericardial, fluid. So it must be pericardial effusion. And you also do the lung ultrasound, and you go to the side and do lung ultrasound. So lung ultrasound, how do? You just go to the side and you look at the costophrenic recess and the angle between the liver and the lung. Then you will see something like this. There's pleural effusion. Instead of seeing A lines or B lines, you see all this black. Yeah, this is a massive pleural. And normally you don't see these fine shadows above the diaphragm. And when you have fluid is a good transmitter of as opposed to air-filled lung. So you see this spine. So that's called spine sign of. So this patient had dialysis and also drainage of this left pleural effusion, and the pericardial effusion also got better in the patient's symptoms. And in the dialysis unit, so the next clinical setting is dialysis unit. So you are rounding in your unit and you auscultated a patient, that is sono-auscultated patient, who is feeling fine and wants to dip time. Normally we do 4 hours at least, right? We try to do 4 hours 3 times a week. That's a quality measure. So if you want to do less than that, and we need to make sure that the lungs are okay. So, but what do lungs do? There is a pleural line, and you see a lot of sun gray or B lines or vertical artifacts, suggesting that this patient has asymptomatic pulmonary congestion. And as I showed this slide previously, the sensitivity of way lower to get this kind of pulmonary congestion. And otherwise, if I do have a sonoscope, just say, okay, fine, you're feeling fine, your KTO is okay. Just decrease your dialysis by 3.5 hours. But okay, so then you come and ask, okay, fine, you're showing these B lines and stuff, but why should I even bother about them if the patient is not symptomatic, right? So B lines do have prognostic significance in dialysis patients. So having a lot of B lines in the lung, more than 60 as opposed to 50, and that compared to less than 15 B lines, has prognostic significance. has impact on cumulative survival and also cardiac events. And this was a big study in 392 dialysis patients. And very interestingly, 71% of the patients with 15 to 60 V lines were completely asymptomatic. So asymptomatic congestion still portends worse outcomes. So you need to care about it. And same next scenario is you're still rounding in the dialysis unit. There is another patient who complains pain at the site of cannulation. So you use your sonar and take a look at the axis. On the left-hand side is the base scale image. Fine, fine, fine. Here there is something. And it's not really connected to the vessel, but there is something outside anechoic structure. It looks like blood, so it must be site of canyon. And you put the Doppler, and the Doppler is not going. That's not a flowing structure. So most likely, what happened was the needle passed through and through. So in difficult patients, using ultrasound guidance to cannulate might be helpful. And here is another patient. You can see the same structure is connected to your fistula, and this one does have some flow, and there is to and fro flow, meaning red is towards the transducer and blue is away from the transducer. So that means there is to and fro flow within the structure, and this must be a pseudo. And to and fro is called the Pepsi sign, red and blue. And the very last clinical scenario, you see patients in the nephrology. So you have an elderly gentleman just with hypertension and no other comorbidities, taking vitamin C and D for COVID prophylaxis. Urinalysis did not reveal any hematuria. There was just 1+ protein on dip state. Otherwise, the patient was feeling okay. It's just that the patient had AKI. The creatinine was 3.5 or something like that from a baseline of 1. And kidneys appeared like this. So, I mean, they appear fine. I mean, in terms of size, they appear long enough, at least 10 to 20 meters. But they are unusually echogenic. They appear too bright compared to liver and the surrounding spleen. So this is how normal kidney appears, right? So we showed this liver, parenchyma, and fat. Parenchyma is usually less bright compared to that of liver, or at least of same brightness. And this is how a ESRD kidney, like when the kidney is essentially dead and fibrosed. Here is on top is the liver, and this kidney is too bright. So that's how ESRD kidney. And when you go back and see the patient's images, and ESRD kidney is also like very small, right? You can see that this kidney is only like 8 centimeters. It's very, whenever you see parenchyma, it's very thin. But here, the kidney is long enough and the parenchymal thickness is good, but it's just they are unusually bright. This is suggestive of AKI. I can't tell you the cause, but in outpatients, generally, when you see such bright kidneys, it's most likely acute nephritis because you tend to have ATN more in the inpatient setting and AIM more in the outpatient. And also, you need to rule out any paraprotein-related disease, which also can. So I ordered SPEP, UPEP, and all those things, and also scheduled for biopsy because you need biopsy anyways. So what did biopsy show? So it showed these crystals. These are calcium, oxalate. So the patient had oxalate nephropathy from massive amounts of vitamin C and D. He was taking this unfortunate patient, otherwise healthy guy, apart from hypertension for his age. He ended up on dialysis, and oxalate nephropathy generally has relatively worse prognosis. Another patient who had kidney transplant was being seen in the clinic, had allograft biopsy 4 months ago, and urinalysis showed microscopic hematuria. And then we performed a physical examination, that is POCUS. So here you can see at the site of biopsy, there is a mixture of colors, not just red and blue. Normally you should have either red or blue color, the blood vessels, because the flow towards the probe is red and flow away from the probe is blue. But when you have mixture of colors, that indicates high velocity flow. And here is the transfer section. You have this like some like mushy multicolored flow, and you put spectral Doppler and look at the velocities. The tracing appears very hazy, right? It doesn't appear like a normal peak and valley pattern. So normally, this is how intrarenal flow looks like. So normal peak, like a mountain and a valley, that's the arterial flow. But here it looks very grainy, and also you can see that the velocity is much higher. It's about 70 centimeters per second, while normal renal blood flow is like 20 centimeters per second. So that's a high velocity hazy flow. So that indicates arteriovenous fistula formation secondary to biopsy. And the patient was managed conservatively because creatinine was preserved and she got better eventually. But you can also see something like this: a patient with recent transplant present with AKI and right lower quadrant pain after a transplant, and you see all this. You see the kidney, and around the kidney, you see so much. This collection with septations, and it could be blood, depending on. If you did a recent procedure, it could be blood with clotting that it gets these septations, or it could be lymph also. Lymph also has fibrin. So in this patient, it turned out to be a lymphocele on drainage. And also simultaneous had rejection. And there is some association with fossil and rejection, whether it's causal. So yeah, obviously, in 1 hour, I can't talk too much. I think we're already exceeding the time. So, POCUS essentially, it's all about practice and having some background knowledge, and the rest is all practice. There is no formal training in the United States as well. We are one of the very few programs who really formally incorporate POCUS training, multi-organ POCUS training into nephrology practice. So you need to choose one kind of research. If you're a textbook kind of person, you read textbook, or if you want to take advantage of online free resources, you can. This is nephropocus.com, and you go to About tab, you see an introductory video that will tell you exactly what resources on this. And I have curriculum videos I made for my best institution nephrology fellows. I also make short YouTube videos. I do it like every month, and I have several case files. So the reason I made this website is that I'm a nephrologist and I don't have any specific resource directed towards me. That is the cases I see in my practice. So I thought I would maintain a diary. Like I see an interesting case that in my practice, and why not put it down with anonymized data and put those images. That way it will be helpful for other people. And you know that what nephrologist really sees in his or her practice. So you will see all those case files, and there are also some quiz and POCUS related literature summarized in the form of infographics. So you find all these things in NephroPOCUS. And I'll finish with a thought that, a fool with a tool is still a fool. You can have POCUS, you can have exceptional technology, pocket devices, you can have finger wearable point of care devices. But if you cannot clinically integrate this data, what you are getting with POCUS, you still remain a fool. And with that, thank you so much, and open to questions.
Thank you, Dr. Abhilash, for such a lovely presentation. And what has really got us interested is how you are using POCUS as a daily decision-making tool as compared to using it once in a while. I'm sure our august audience today has a lot of questions. But before that, just a small question. How do you interpret an inflow stenosis into the fistula versus centimeters per second flow velocity to an ml per minute flow velocity?
So in generally, we don't perform access ultrasound that much. So if we do have some suspicion of turbulent flow, I would rather send it to interventional nephrologist, because most of the interventional procedures, at least at this time, are done using fluoroscopy. So whether I spend time and do point of care ultrasonography in the dialysis unit or not, it rarely matters. So if the access pressures are high, and if there is some suggestion of stenosis or by turbulent flow or high velocities, in general, we just send it to the intervention. Yeah. I don't have a specific answer to that question. We did those studies before, but we did not find it's really practical in our practice setting. So that's why I'm like, really, most of the procedures are done here by interventional. Even interventional nephrology is very small group. It's not like every institution has interventional. Mostly they prefer vascular surgery or interventional radiology. It's only few institutions that have intervention.
Yeah, great. Because also what was really interesting was your depiction about the IVC diameters, and we are really falling short of our experience when we are trying to interpret IVC diameter, especially in ventilated patients versus spontaneously breathing patients. So any elaboration on that, sir?
Exactly. So in ventilated patients, IVC is always big, and it may or may not collapse. It does collapse with expiration, But when it does collapse, it's useful. If it doesn't, if it's plethoric, it's not really useful. So adding these portal vein waveforms and hepatic and renal waveforms when available is a much better way. So these waveforms are not necessarily affected just by the pressure of the positive pressure ventilation, unless you have some tricuspid regurgitation going on, or there is really elevated right atrial pressure. These waveforms are not altered just because of mechanical ventilation. So adding these waveforms or venous excess Doppler ultrasound is really a great adjuvant to their IVC ultrasound is also very subjective, right? Today you are seeing the patients in ICU, you document something. Tomorrow your colleague comes and he or she might not measure the IVC at the same spot, or IVC is a tubular structure, right? You can have cylinder. So if it's a tubular effect, if it's a tube, you might not be slicing the IVC at one particular area, the middle, might be slicing it in the side, so that way you don't get accurate diameter always. So person to person variations occur a lot. Irrespective of what studies show, in real life, there will be a lot of variations. The same person is not measuring the IVs every day. So you need to have one other parameter. So, I mean, measuring these waveforms will give more objective. If you're able to save the images, that's really great. And somebody else see your
Yeah, thank you, sir. Thank you so much. Are there questions, sir, if any?
Yeah, in a typical nephrology practice or your own practice, what is the kind of instrumentation which should be accessible to a nephrologist to start this point of care?
Yeah, I mean,
which kind of ultrasound machines? How many ultrasound machines?
It depends on, it completely depends on your practice. So, first I'll say from academic standpoint. In academic standpoint, you are having some nephrology fellows, you want to train them, so you want to give them as much as hands-on experience as possible. The advantage is that usually in the hospital, in the teaching hospital setting, depending on your resources, you should have some machines available for the use by training. And for doing procedures, so there are two different things, right? You are primarily asking whether we should get handheld ultrasound device or a bigger ultrasound machine. So the bigger ultrasound machine has its own advantage. One thing is, for procedures, it offers better ergonomics. So it has its own stand and all those things. It makes you more comfortable. And also it has features like spectral Doppler, which is measure the blood flow velocities. It allows you to do better evaluation of cardiac pressures. And it also has tissue Doppler. Tissue Doppler is used to evaluate the left ventricular filling pressures. It also can have EKG guidance. So when you are evaluating these waveforms, the portal one I showed is like, but hepatic vein waveform can be little if you don't have a simultaneous EKG tracing. So the bigger machines have all the bells and whistles required to perform advanced. But the downside is that it is expensive. I mean, I don't know how is the billing structure in India, but if you're able to pay for those studies, you can still get back the revenue. It's not that I'm saying like they're out of for physicians. You can still buy those big machines in practice, and you might get discount because ultrasound companies might be willing to give you a discount depending on your scope of practice, and you can bill for those studies and get back your investment. So that's a downside. And the other downside is if your practice involves going to multiple hospitals and multiple practice settings, you may not be able to carry that device wherever you go. That's the greatest advantage in my mind, rather than and just the cost alone. So, and coming to the handheld devices, the greatest disadvantage of or greatest advantage of handheld devices is the cost. So for as less as like $2,000, you get a butterfly device. $2,000 is what, like 13,000 rupees, right? I don't know exact translation, but regardless, it's very cheap in today's terms. But the problem is the image quality is not so great. You use that butterfly device, you do cardiac ultrasound. If you learn cardiac ultrasound with a bigger machine and you will clearly know that it's fine. If you are already an expert and you're doing with butterfly, that's completely fine. But for novice users who are still learning, it might be a little tricky if the image quality is not. So, and it also doesn't have spectral That means you cannot measure velocities. That means you cannot access, you cannot say if the axis is mature enough or not by measuring the velocities, or you cannot do Doppler cardiac ultrasound, or you cannot do this Doppler. And similarly, here Philips Lumify offers great image quality, but some people feel it cumbersome if you have to carry 3 different probes and connect to your device. On the other hand, Butterfly offers just like 1 device and 1 probe. That's another advantage of Butterfly. But yes, and Lumify has great image quality, but it has 3 probes and also it's expensive than Butterfly. Lumify, I think each probe is like $5,000 or something approximately. So if you're buying those 3 probes, your investment is like $15,000, which is fairly significant for an individual person. And another device, GE Scan. Scan is also good, not as good as Lumify, but okay. But the advantage is that you have a dual probe. One side of the probe, you have the phased array, which you can do cardiac ultrasound or basic ultrasound. On the other side, you have this vascular probe, vascular access ultrasound or lines. It comes to around like $1,000 approximately. And the newer device is Cosmos. Cosmos device has spectral Doppler, greatest advantage. And that comes with its own device, own display device. You don't need to use for something. And it's also not advisable to use your personal, iPad or phone in general. I mean, the hospitals might allow now, but it depends on how strict your patient privacy laws are. I mean, as the laws become more strict, it's not advisable to share save any of the data in your personal device. It's always good either get a hospital provided encrypted device or buy a device that will avoid problems with data. Yeah, so that's Cosmos has spectral Doppler. That way you can perform most things. The price point is around, I think, $10,000 to $12,000. Yeah, so basically it all depends upon what sonographic applications you want to perform and what your practice setting and your budget allows. That's a long answer, but I hope I answered.
We have been using ultrasound in our practice for last few years. We have gotten access to sonography machine in our hospital, and it has been very useful to us while doing biopsies, looking for post-biopsies, hematomas, then looking for transplant kidney Doppler, putting perm cats, putting temporary catheters, looking at the IJB on either side before putting the catheter. So the catheter administration becomes very easy, and you know which side to put in, whether there is a pre-existing thrombosis or narrowing. And it has been very useful to us, and we are learning a lot by using ultrasound in our practice. Because there is accessibility to this machine in our hospital. We are learning a lot by using it in our clinical practice.
And you can also buy a used device. It's not that you have to always buy a new device. You get used ultrasound machines for cheaper price, and most of the card-based machines still have all the features that you begin with. And you can always upgrade the device. If you feel confident enough, if you have enough revenue generation, you can always upgrade it.
Sir,
so it looks like
yeah, one thing I saw interesting in one of your images was the graft kidney showing the peritoneal reflection. So is it often to come across the reflection of peritoneum in graft kidneys when you are looking for biopsy, because you wanted to avoid puncturing a bowel also?
Can I show that image? Probably not. I mean, the general question is, yeah. I mean, you can identify bowel when you're doing transplant kidney biopsy, bowel gas shadowing. That's not a good thing to do. We just ask the interventional radiologist to do. But I don't think it's in one of my images, unless I don't remember. I think I showed one transplant kidney where there was post-biopsy arteriovenous fistula, and one was having lymphocyte. But yeah, we did have like bowel, but in our practice, like I said, like we are very easy with procedures. We are not like procedure intense in most academic places in US. That practice has gone mainly because of monetary reasons. Like when you graduate and go out, like the time you spend to do a procedure and the amount of revenue you get back doesn't correlate really well. That's why people don't do procedures. That's a real reason. So so academic places also don't really teach that much. I mean, in residency we put catheters like left and right. That's why we know. I mean, and using ultrasound is mandatory. It's a patient safety concern. So you all learn using ultrasound for central venous catheter placement and dialysis catheter. But apart from that, any sign, like fellow wants to do a kidney biopsy, okay, fine, we go and do it. But at any point we are not comfortable with anything, just all the interventional radiologists and they do it. That's how it works. We are not as experienced as blind procedures, or even like that. We don't do that much procedure.
Yeah, thank you, sir. Any more questions?
Sir, this is a question to the entire forum, especially in the Indian scenario. What are the current licensing practice, or rather the current licensing guidelines by the government while buying a full sonography machine versus a handheld sonography device? Yeah, anybody could give their views?
I think you can buy it, but you have to register in PCPNDT about the machine, and PCPNDT who will be the end user. So whosoever uses the machine has to submit his registration certificate and his degree certificate in PCPNDT and get registered himself for using that machine. So,
despite the fact being that machine, or rather that handheld device, won't be used on any of the ANC cases.
yes, it is still you have to register the machine in PCPNDT, and you have to register yourself if you are going to do the ultrasound. So here we have registered ourselves in PCPNDT because we are doing ultrasound in our department. So we have registered ourselves into the PCPNDT by submitting our registration certificates.
Right.
So is there a problem with handheld devices because of the prenatal gender determination and those kind of laws in India? That's what I heard.
Yeah.
Right. So is there an issue with the handheld device as well in India, or is there any leniency for the same?
No, I meant like I heard it's very difficult to get handheld devices, not because of the cost, but because of the laws governing the prenatal gender determination. That's why like people say we cannot buy handheld. That's what I heard like long time ago. I don't know what's.
Dr. Anand, you wanted to ask a question?
Yeah. Good evening. That was a really wonderful presentation and impressive work. Dr. Abhilash, I just have a couple of questions. Like, I just want to know, like, what are all the challenges that you would have faced while implementing this NephroPOCUS into the curriculum of a nephrology fellow? Could you share your experiences with that? Because as of now, we are at least the newer pass outs or the recent pass outs, our DM programs, which the nephrology programs or the DNB programs, we do have exposure to ultrasound, but we don't have an organized exposure. So having implemented it in with your nephrology fellows, could you share some of the challenges that you would have faced while doing that?
Absolutely. Yeah. Nice to see you. I remember you from Twitter. Anyway, so there are two things here. So the first thing is that it can be done by one person. I mean, you can lead the program. You can push for it. But you need to have support from the leaders. If the division leadership or nephrology leadership is not in support of your program, that's going to die, because they have to provide you with the monetary support and the time support. Generally, in academic practice, you need some time, right? So, I mean, you have less pay, but more time to academic activities. you're running a program, if you're really building a program from scratch, you need to have sufficient time to dedicate to that program. You can't be like seeing patients from morning to evening and say, establish some program because you're scanning some patients. So to design a curriculum, you need time. So that's one practical challenge, but it's not that difficult here. Patient load is not anything compared. I mean, I did my MBBS in India. I know how internship is and how many patients you see. So it's not that horrible. So if I need time, I can ask for time. That's one thing. And second thing is expertise, right? And not because nobody is trained in ultrasound. I was not trained in ultrasound. I did several things. I went to several courses and I think important thing that really helped me is that once I got a better idea of anatomy and how to scan, I used my own institutional resource. I went to people at our institution who do. In US, at least, POCUS is very well established in emergency medicine. So all emergency medicine residencies have to have POCUS training. That's their mandatory graduate and pass their board. I went and shadowed and did some observations, rotations with emergency medicine physicians. I even shadowed or observed vascular technicians to get a better grasp of vascular ultrasound, because vascular is slightly tougher compared. So I used institutional resources. So obviously you're not going to have trained faculty, but it's important that you have a faculty who is willing to utilize everything in their capacity to improve their knowledge. That's when the programs are right. It's not that you went to a course or your faculty is sponsored to go to a course and did 1 week observership somewhere and go back and you're perfect and you are able to your 10 fellows. So you need to have that bent of mind, keep improvising your skills and knowledge. That's the thing. And next thing is obviously the machine. Whether you are in academic setting or private practice setting, money is definitely an issue. So you need investment for the machine. You can just say like, I'm going to teach the fellows, so just give me machine for free. It's again all about money. And that's how I know, like, you can buy a used machine. So at my previous institution, I convinced the chief to get a used. So used machine was like less than half price of the new machine, and it has all decent features. And it was like 4 years old machine or something. It's not too bad. So that's one thing. And if you are buying handheld devices, that would reduce the cost. But the problem is you need more handheld devices, right? You can't just buy one handheld device and say like all your 10 fellows use the same device. You need to buy at least 3 or 4 devices. Buying handheld devices for a program. And another thing to offset the costs of the machine is to bill for the studies. And I mean, probably some of your hospitals have electronic medical record system, right? You probably have saved these patient records. So for us to bill for the studies, you need to save the images to a centralized image archiving system. That will facilitate billing. And if you don't save images, you can't bill for that. So you talk to your IT department and set that up, image archiving. And image archiving is also important. So you are not always sitting beside your fellow. So they do studies independently and they save the images, and then you can review those images and give feedback. You won't give feedback if nobody's reviewing their images. Practice is good, but it's like a blind practice, right? You can still, when you don't have like a well-trained faculty, you can still make a lot of mistakes. So when you save images, that's really good. So images that are not saved are called phantom scans, and phantom scans are strongly discouraged. So setting up that thing is one problem, but like I said, like all these things, these are the main hurdles, like faculty training, procuring a machine, and image archiving, and setting up the billing process. So to do these things, you need to have good support. And there are still several hospitals which do not trust that. When nephrologist is saying, no, I do Doppler cardiac ultrasound, who's going to trust you, right? So you need to get some certification. So that's why, fortunately, we have this. Cardiologists have this National Board of Echocardiography examination. Similarly, critical care physicians also have. So I'm allowed to take critical care echo boards. So I did that thing. So that gives me more credibility. So you do some kind of certification international, and that will help your hospital administrator to trust you. And yeah, and depending on your your chief pushes, or it depends on your leadership hierarchy there, but if you're a powerful person in the division, for it will happen. Because it's not really too expensive in the grand scheme of things. It's ultrasound machines, maybe like total you might have to invest like say $40,000 is probably not a lot today's.
Yeah, as you rightly pointed out, certification becomes important. Like, are there any resources which should provide us certification with all this COVID going around? So, in physical training might not be a feasible thing. So, is there any online resources that you could suggest?
So for in general for nephrology, there is none. So we have to depend on resources that offer certification online, maybe for the emergency medicine physics. One thing you can check out is POCUS Certification Academy and what they offer. Generally, it's more of a certification alone rather than some online course. You can check that out. And if you're more looking for Doppler echocardiography, you can actually not only for Doppler echocardiography, you can check out the website 123 Sonography or 123 Echography. It will be there like sonography, I think. That's a very well organized online course. Relatively expensive, but if they offer discounts or if they're able to get that, that's great. There are different online courses, certification courses actually available for basic echo, Doppler echo, abdominal ultrasound. I actually took that course. That's how I know it's good. But I had some educational grant money, so I spent that. Yeah, 123 Sonography I think is the best resource that comes to my mind right now. And in ASN, we are organizing, in this year ASN also we have a small course, but even though I'm course director, it's a conflict of interest. I say those kind of things are not really helpful, especially for someone coming from another country and learning those short sessions. Yeah, because it's too short. I mean, by the time you get some hands-on experience, you hold the probe, it's already over. You don't get much. And next year, hopefully, we'll offer a e-course. So if this year's course is I mean, like the people, if people come next year, we'll offer it as a e-course, most likely before ASM. So that would be 1 or 2 days, and that might be little.
Yeah, and just one final question. Now that we know that ultrasound is being a very exciting tool, so how's a day in your practice with ultrasound? Like, how does it go? Do you use it in all the AKA patients, and like as you said, as a fifth pillar of examination? So how does your round go in a day? Like, we don't use it, so we depend on the sonologist. We don't have the luxury of these devices. Not all the places. Most of us do have the devices these days. So how does a day of your nephrology rounds go? Like in assessing patients, do you use it in every patient, or how do you go about?
Depends. I mean, if there is any, mainly I use for what status assessment and follow up. But in general, if you see, most of the nephrology practice is about volume scans. Right? I mean, you don't see complex glomerulonephritis every day. Most of the admitted patients have some sort of volume issue, even if it's nephrotic syndrome or glomerulonephritis. The things that you change on a day-to-day basis are volume related. You're not going to change immunosuppressive therapy, especially lupus or anything. So for that purpose, yeah, we use quite frequently because our fellows are also very interested. So we have one big machine, two GEV scans, and one I have a demo machine provided by Cosmos. I have to return that somewhere, but in general, so that means at least currently we have don't have, and so we have sufficient devices and we can scan patients. So basically, the way we are organized is, I don't know how it is there, but in general, we are on different rotations at a given point. I might be on inpatient rotation, or I might not be. If I am on inpatient rotation, there will be more scans performed. If I am not, there is somebody else. They still call me for complex cases, but it's not that they're doing on so many. We use the small handheld devices. So if you're doing lung ultrasound, just A or B lines, it's very simple, right? So for that small GEV scan is good enough. You don't need to spend a lot of time pushing the patients. So our fellows like that enhanced portability. Most of the patients, they just use lung ultrasound. Then you can also look at basic IVC and all. In patients who you want to do the VEXUS study or the venous congestion studies, more Doppler echocardiography, you take the bigger machine. And fortunately, our clinic, the outpatient clinic and the inpatient buildings are well connected. So the machine is always located in clinic building. So if I'm on nephrology clinic, I use the machine quite frequently. So I have a specialty clinic, cardiorenal clinic. So any patient, anybody places a consult request from cardiology or the indication says cardiorenal or something like that, the patient starts because I take care of that. So in general, it's a common practice that we have specialty clinics. So one person patients and one person lupus patients, something like that. So I see cardiorenal, that way I can employ. And when I go to outpatient dialysis units, and dialysis units are not connected to hospitals, so we rely on handheld device. And anyways, in outpatient dialysis unit, the patients are in those chairs, right? So they're not really the most comfortable chairs. But if you want, for physicians, like you'll have back pain very easily if you try to spend too much time there. So all you want to do is like quickly get the lungs and get the basic heart if you can. But other than that, you can't spend too much time. I mean, some dialysis units may have attached rooms where you can put the patient on a bed and probably do more examination, but that's not really practical. It's all shift system, and 3 shifts to go. You can't spend like 20 minutes doing a full access exam for a dialysis. This is how it goes in general. You choose your device depending upon on the location and what you want to.
Yeah.
Thank you, sir.
Thank you so much.
From your last question, taking a cue, Dr. Ashish Shingare from Mumbai is asking whether there is any cheap alternative to USG phantom models for biopsy and vascular access.
For vascular, I mean, if you're looking to just teach the like how the needle appears and stuff, I mean, you can make some models at home. You can actually look at like search in the YouTube and find emergency medicine physicians use it. You can use this, like a big skin and stuff. So you can use those things. Yeah, I mean, rather than me saying those, you can YouTube and then show you like how to use better. Actually, there are some papers also on. But if you're mainly talking about guiding the needle, you can actually do a kidney model also using a core kidney or some animal kidney, whatever is available locally. Yeah.
Thank you, sir. I think we can go on, and we'll never be, full with all the new information that you're bringing to us. Thank you, sir, for such a wonderful session. You have really got us stimulated into using POCUS more and more in our daily practice, and we cannot thank you more. Thanks a lot.
Thank you so much. Yeah, thanks for having me, and nice to meet you, everyone. Thank you.
Thank you.
Okay.